We good? I think so. Cool. Thank you for those great talks. Shifting gears a little bit. So I've got 15 minutes, and everybody started by saying I've got 15 minutes. I also have 15 minutes. And I would love to spend an entire day talking to you about things like the microeconomics of the drug trade and all of the intricacies of public health and addictions. But I don't have that time. I thought I would spend the limited time that I have speaking to you about the space between examination rooms and ivory towers, right, where real life happens. Real life is happening around us with regards to this opioid problem that we're having. And I hope that in these 15 minutes I can convince you that we as physicians and people who are decision makers have a role to play in that real life environment. All right. Clearly the work that we're doing at the level of clinical interventions is important, but there are a number of factors that are happening in that space between that will change how those changes are responded to, and I'd like to talk about our roles in that space. So, in terms of disclosures, no direct or indirect financial relationship with any industry, including pharmacy industry. I have spoken at events that are sponsored by, or conferences that are sponsored by industry. I have never accepted any honoraria personally from them. I do, though, practice clinical addictions medicine, which means that the more opiates that we all prescribe, the more opiate addiction there is, and the better business does. And that faces us who practice pain or addiction or any part of medicine with the inescapable reality that the very things that give us expertise and experience to talk about these things that we talk about and say the things that we say might make you question what it is that we say. I think that could be no more true than physicians talking about the opioid crisis, and I'll just park that with you. I have worked in government where they can tell you what to say and what not to say, and sometimes the agenda inside governments and health authorities contain elements that are not consistent with the interests of public health and safety. I will park that conflict of interest with you as well. So, I could go on and on about conflicts of interest that relate to the opioid crisis, the role of the pharmaceutical industry, the movement of pain as the fifth vital sign, the movement towards patient satisfaction as an indicator of the adequacy of care, all those things that might have had some substantial role to play in the mess that we're in today. But instead, I'd like to talk to you about some other internalities and externalities that affect the way that we see ourselves. Here is an example of how pharma doesn't just play a role in how we decide to treat things, but a role in how we decide whether or not some presentation is a condition that we must treat therapeutically with medications. So, the Book of Woes, the DSM-5, is an example of this, where when the School of Ethics at Harvard looked at the composition of working groups that comprised the DSM-5, what proportion of them had significant ties to pharma. Okay, and by significant, we're talking about tens of thousands of dollars in grants in the preceding year to the work that they did in DSM-5. And you see that in certain categories, 100% of the working group had received financial grants from pharma, particularly in sleep disorders. Makes you wonder why we treat sleep disorders the way that we do, in addiction, and in psychiatric disorders in children. Some of those categories are scary to think of how much influence pharma has had. In terms of how we see ourselves, though, this is an example of an ecological study that looked at how do suicide rates as an indicator of a population's mental health vary with the number of psychiatrists in a population, or the density of psychiatrists, or presumably those populations where psychiatric care was more available. And conversely to what you might think, the more likely that you were to have a psychiatrist to access, also the more likely you were to commit suicide in men and in women, even when standardized for gross national income per capita. Okay, now there's all sorts of chicken and egg arguments that you can make here. There's all sorts of ecological fallacy in here, but it should at least give us some pause. It's not just psychiatry. This happens with all of us. So this is a kind of cute study that was published in JAMA last year. And I promise I'm trying to land a point here. But this is a study that was published in JAMA last year, where they looked at the 30-day mortality in patients who presented with major cardiovascular events at times when cardiologists were in-house versus times when they were likely to be at national conferences. And interestingly, those patients who were categorized as high risk for mortality did better when cardiologists were away. They were more likely to get percutaneous coronary interventions if the cardiologists were there, but less likely to live for 30 days if they were there when cardiologists were there. Now, again, I wouldn't draw any hard and fast conclusions from this. When I have my MI, I would like cardiology to be in-house, but it should give us some pause. And the question that I think we ought to ask ourselves is, do we have the positive health impact that we think, or that we say, or that we try to prove that we do? And I think that I can't think of a better example than in the way that we've approached pain over the last 20 years that illustrates this. So the best way that I could kind of sum this up is something that my mom tells her narcissistic children: don't take yourself so seriously, no one else does. It's hard for us to take our work seriously when we're so busy taking ourselves seriously, I think. And again, my mom, I think, describes this opioid crisis quite well. I can't think of a lot of areas in medicine where we've gotten so entrenched in debate, taking ourselves so seriously, forgetting about the impacts that our work is having on the space between our exam rooms and those ivory towers. So, that work has gotten very, very serious. You've seen the data that should be very convincing to anybody who had any form of doubt. You see that it is happening in demographics that are very concerning for all sorts of reasons, from a PYLL point of view, from a socioeconomic point of view. Young people losing their lives to opiate overdose is just inexcusable. Those are the numbers. These are their moms. So on the left there you see Donna May in Ontario, who lost her daughter Jack, who by all accounts was a fiery, clever, capable young woman who started her opioid career with prescribed oxycodone. She graduated to injection drug use. She died after complications of necrotizing fasciitis and an overdose. Donna May spoke at the UN earlier this year, and she'll speak at the National Summit on Opioids, and you can imagine what she has to say about us. Two down from her is Petra Schultz, who's from Edmonton, and I hope that some of you have had an opportunity to meet. She's holding a picture of her 25-year-old son, Danny, who, again, was prescribed oxycodone. He graduated to injection use as well, died from a hit of fentanyl. These are not people who you would stereotypically think is somebody who's addicted to drugs. There is no such thing as the stereotypical face of somebody who uses drugs. Danny was a Red Seal chef who schooled at culinary school in Vancouver. He was liked by all of his colleagues, and unfortunately, he's no longer. I could show you a picture, oh, actually Nick did, a picture of Rosalind Davis, who's somebody who in her 30s lost her partner, who was a PhD with an MBA and a successful stockbroker who lost his life to a fentanyl overdose. And you can imagine not just the detriment of losing somebody with those kind of credentials, but also to a woman in her mid-30s who had bought a house with a guy, who was contemplating having a family, who now has to start over somehow. Tip of the iceberg. This is what the CDC, because they have good surveillance around health behaviors, which is something we would like to see in Canada, has shown that in 2008, of the almost 15,000 prescription painkiller deaths, there were 130 times that number of deaths in people who had an addiction disorder. If you take our fentanyl deaths, and if you assume that all of our other opioid deaths were the same in raw numbers today as they were in 2013 with no growth, and assumed the same case fatality rate, not taking into account that many people who don't have addiction die from opiate overdose, we could have up to 70,000 people who suffer from opioid addiction in our population. I actually think that number is probably higher. What proportion of them had issues with prescription opioids before graduating to illicit opioids? I've seen comments on CPSA website about there being two types of patients, some who use illicit opioids irresponsibly, shame on them, and some who use their illicit opioids responsibly, good for them. There's no such dichotomy. There are shades of gray throughout that. John Oliver, who performed a surgical takedown of our profession on Sunday, put up the New York Times article that showed 75% of people using heroin in an addicted fashion in the United States use prescription opioids before turning to heroin. Okay, we're complicit in all of this. There's no debate about that. So I think this comment from Sir Winston Churchill is apropos. When the facts change, I change my mind. What do you do? We don't debate an old position. I think in medicine, we change. And the beauty of medicine is that in spite of it being peppered with mistakes, we consider new evidence and we move forward from there. Some of you may know Russell Portnoy, who was a very vocal advocate for chronic opioid therapy in the 80s and 90s. And here's what he told the Wall Street Journal. If I had an inkling of what I know now then, I wouldn't have spoken in the way that I spoke. It was clearly the wrong thing to do. I think we all need to have that kind of intellectual humility. Because after all, the history of medicine is punctuated with really, really big mistakes. In the late 1800s and the early 1900s, some of you may recall pictures of Mrs. Winslow's soothing syrup, which was advertised as more soothing than a mother's kiss. And why not? Because it contained morphine, hydrochloride, codeine, heroin, powdered opium, and weed. Okay? We also had remedies like this for toothaches. So it's not that these medications didn't work, but they had some side effects. More recently, we discovered that long-term hormone replacement therapy was probably not as advantageous and probably came with some serious harms. We know that COX-2 inhibitors were not as effective and safe as we were told. You remember this one, right? Governments are still paying out victims of thalidomide. And I can't think of a better example than this. So the prefrontal leucotomy or the lobotomy did not happen that long ago. This was invented by Antonio Egas Moniz, who is a brilliant Portuguese physician who also, by the way, was one of the founders of cerebral angiography. He developed this procedure for psychotic conditions that were refractory to other treatments. He received a Nobel Prize for this, by the way. Not only was this something that we did, it was something that we celebrated. And it was done, its uptake increased from hundreds per year to over 5,000 per year in 1949 in rooms like this. And in patients who presented not with psychotic symptoms, but many of them soldiers returned from war with mood disorders and anxiety symptoms that were post-traumatic. This was not a dumb physician. This was a smart fellow who had done great things in medicine. And this was a blunt intervention that was aimed at extinguishing symptoms related to subtle intricacies in conditions in which it was never studied well. Does that sound familiar to you? I'm not calling chronic opioid therapy the lobotomy of the 21st century, as good as that would look on Twitter. What I am saying is that our responsibility is beyond our patients. It's to the science and it's to the population and it's to humanity. I know that that sounds very kumbaya, but this is from the American Medical Association's Declaration of Social Responsibility, medicine's social contract with humanity. And this was a change to their code of ethics after 9/11 when there was an outpouring of physician support saying, what else can we do? What can we do to support this population beyond our clinical examination rooms? And the credo came, humanity is our patient. And I think that that's something that we ought to internalize as well. Dr. Thiemann, in his invitation to this event, said, we can't do this alone. We need better coordination, better information, and the commitment of many different stakeholders if we're going to make a difference. I don't think any of us could have put it better. This is not just a clinical issue, but it's an issue in spite of that that requires our participation as a profession that is partly, if not largely, responsible for what's happened in our population. Here's the thing, though. That forces us to play in arenas that are not our natural habitat, right? Health professionals, including those who work in ivory towers, are not naturally inclined to work effectively in groups and not naturally inclined to make policies well and aimed at effectiveness. Here's a couple of great pieces of advice that, that I refer to often when placed in those situations. One from Milton Friedman. One of the great mistakes is to judge policies and programs by their intentions rather than their results. Not a lot of better examples in drug awareness education. Of course, that sounds like a great thing to do, but you'll be hard-pressed to find in the literature great examples of where that's effective. And you will find examples in the literature where it's counterproductive. You've heard of DARE. You remember Just Say No. And certainly there were elements of poor drug awareness campaign with a website called Drugs Fool. And I'd love to go into a takedown of why that doesn't make a lot of sense from an evidence point of view. It's gotten better with more focus on harm reduction messaging. But also, as we move towards clinical interventions to reduce opiate prescribing, there are unintended consequences that we ought to mitigate. So in spite of the fact that we're aiming at a noble goal, we have to keep in mind that there is a broader real-life scenario between our examination rooms and the ivory tower that we also play in. Here's another great example from Heath Ledger. Can't tell you the key to success, but I can tell you the key to failure is trying to please everyone. That applies to multi-stakeholder groups that are looking to make an effect on public health and safety. By the way, Heath Ledger died in 2008. Does anybody remember how? Prescription opiate overdose, oxycodone, Xanax, temazepam, hydrocodone. All prescribed to him, by the way. So the thing about pleasing everybody is that it's very quick that multi-stakeholder groups evolve from a singular focus on protecting the public's health and safety to a focus on achieving consensus or appeasing competing interests. We need to move back to that singular focus, regardless of what the agendas are from our masters. I'm going to put up for you a couple of statements, and by a show of hands, tell me whether or not you think these are good things. So the first one is, the involvement of multidisciplinary teams in advanced psychosocial interventions is critical to achieve commonly targeted health outcomes in patients with opiate use disorder. Good or bad? Sounds pretty good, okay? Educating children and adolescents on the harms of drug use and awareness campaigns that advise drug users about the perils of new substances are important and effective prevention strategies. We must address this problem upstream. How does that sound? Show of hands, good statement? Yeah, nods around the room. Public health issues arising from complex factors can only be impacted by methodical, deliberate, and measured responses that engage multiple sectors and stakeholders, and they take time to execute. Absolutely. Doesn't that sound like a smart thing to say? You seen this? A platitude is an idea, A, that is admitted to be true by everyone, and B, that is not true. That's from H.L. Mencken. What you saw there, actually, the latest Cochrane review shows that multidisciplinary teams and advanced psychosocial interventions offers no marginal benefit in addition to agonist maintenance therapy for opiate use conditions. Okay? That is not to say that some patients don't benefit from it, but what it is to say is that when we're in emergency and we need to achieve the greatest good for the greatest number, stop trying to be fancy, man. Like, we need to pull people out. The education we talked about, drug awareness campaigns are notoriously for not working and doing harm. And third, what the hell does that mean? It is an excuse for taking long to get something done, but we're not in a position, if you think clinically, if you are in an urgent situation Would you convene a working group when somebody has an MI to talk about the cost of healthy groceries? Probably not. You would save the life and hope that we can sort out the other stuff later. I'm going to move on to just the 3 evidence-based public health interventions to reduce opiate overdose death that have great evidence. The first is naloxone distribution programs, and because Nick put up a picture of me, apparently I'll put up a picture of him. Congratulations. Congratulations to the needle exchange programs and to Nick and his team for putting this on their back and getting this done. If we achieve a rate of 1 in 1,000 people having take-home naloxone, we should be able to reduce opiate overdose deaths by half, but we know that people have to use this multiple times. And with more and more toxic opiates, we know that people have to use higher doses of naloxone to save a life, and it is the quintessential Band-Aid solution. Agonist maintenance therapies, we have not nearly enough access to it. We have fewer than 5,000 people on methadone and buprenorphine. Many of those people on buprenorphine are on it for pain. And as I said, we probably have somewhere in the neighborhood of 50, 70,000 or more people who are addicted to opioids. Finally, supervised drug use services. I'm so sorry that I'm coming to the end of my time because I would love to spend a half hour on supervised drug use services. There is no excuse for us not having had this public health service before fentanyl happened. And now that it has, there's even less excuse. There is no room for let's consider. There is no room for let's explore. There's no room for let's look at. There is nothing to stop us from doing this except for some legislation that we could circumvent or that we could appease by getting provincial support for this intervention. I'll gloss through this, but in terms of the level of engagement in the United States, this is something that has Obama's attention. We need that kind of attention here. We need advocacy from strong voices like you to make that happen. There, systematic review shows supervised injection sites are a good idea. Go look it up, and you find no shortage of evidence that supports these. You will also find no shortage of evidence that this is a cost-effective solution with high cost utility as well. There is no reason for not having these in Alberta and throughout the country. And I think that the work that Elaine Hishka and her group, AMSIS, is doing to make this the least objectionable to communities is brilliant, and we should be supporting it very, very quickly. The issue of heroin maintenance. Some of you may have read on this. There's good evidence for patients who have opioid addiction that's refractory to conventional therapies that this is cost effective. It may actually be more cost effective in those patients than methadone. The one thing I would say, though, is that medicalizing heroin does not obviate the need for healthy public policy. Okay, not everybody who uses heroin is addicted to heroin, and not everybody who's addicted to heroin would meet criteria for heroin maintenance. But public policy that criminalizes drug use we know doesn't work. I like this one. Trying to stop drug addiction by waging war on drugs is like trying to stop OCD by waging war on taps and light switches. You can't declare war on an inanimate object. To declare war on drugs is to declare a war on people who use drugs, which is many of you, if you think about it. London School of Economics, not a bad school, and 5 Nobel laureates wrote a paper on why the war on drugs is stupid and must come to an end. I know that public policy is out of our clinical realms, but we have a role between our examination rooms and the ivory towers to influence this. Those things that are outside of our direct control are not outside of our influence. And if we want to turn this around, if we want to redeem ourselves as a profession, we need to get involved in all of this other stuff. So just to tell you the final bullets, we have direct influence over supply side variables, and those supply side interventions are also demand side interventions in that reducing how much opiate we prescribe will also reduce the burden of addiction. There are other demand reduction interventions that are also under our direct control because we can provide them. There is a need for vocal advocacy from all of us on those things that have good evidence that should be applied immediately, not considered or looked at or explored, but applied immediately in order to reverse this trend of opiate overdose death, including smarter drug policy. Remember that there are unintended consequences to the clinical interventions that we apply. And so that doesn't mean that we shouldn't do them. It means that we should do everything simultaneously, particularly harm reduction, so that we don't make things worse. And finally, consider the patient as our population, right? Humanity is our patient. And their presentation is emergency, acute on chronic. When somebody presents with an acute on chronic presentation, we act urgently, not in a year and a half, but now. And that's what I would hope that you're all advocating for. So thanks.